Hello, welcome to MD Insights. I'm Matthew Walsh of the Digestive Disease and Surgery Institute at the Cleveland Clinic. And it's really a pleasure for me today to welcome Diya Alaedeen, who's a general surgeon. And we're going to talk about hernias, but Dr. Alaedeen, talk to us a bit about the practice of general surgery and what made you interested in that.
So general surgery is pretty much nowadays defined as surgery of the abdomen. Back in the days, general surgery was a surgeon was doing everything, was doing the thoracic surgery, was doing abdominal surgery, and was doing all kinds of surgery. But nowadays, we've got so much subspecialties that a general surgeon like myself would do mostly abdominal surgery or what we call GI surgery. We do quite a bit amount of hernias and gallbladders. Those are the most common surgeries that we do in our practice. And then the other thing is we take acute care surgery, which is any emergencies that come through the emergency room, like small bowel obstruction. And in my practice, we also cover trauma surgery at Fairview Hospital.
So that's quite a wide-ranging practice. Is that what you find exciting about it?
Yes, and I add my practice, as part of my practice also, I do endoscopy, so I'm a surgical endoscopist. But the most exciting things about being a surgeon is this concept that I can actually physically rid the patient of their disease process within hours of an operation. Usually most operations can last either a few minutes to an hour, but the actual concept, if we just hold back a little bit and think about it, of actually getting rid of that disease process physically it's very, it's a huge privilege and a huge honor, and it's a great thing to do and be able to do as a surgeon.
One of the things you did talk about doing as part of your practice is managing patients with hernias. So in general, what is a hernia? How would you explain that to a patient?
So hernia is pretty much the aspect that there's an orifice that's not necessarily supposed to be there. And part of the viscera or part of the bowel or other organs that are not necessarily supposed to be in that orifice traverse that orifice to a different cavity. The simple aspect of a hernia would be the abdominal wall hernias, which we deal with quite a bit, which there's a defect in the abdominal wall, either in the groin or the umbilicus. Those are usually the common ones. Or after a patient has had surgery and there is an incision that weakens over time and there is a hole in the abdominal wall that allows the organs inside the abdomen to traverse that hole. And that's what causes a hernia, or the bulging where the patients feel the pain and the bulging on the abdominal wall that we necessarily have to fix.
So if we talk specifically about groin hernias, do those occur equally in men and women?
No, groin hernia is actually much more common in men. And the embryological thing that we think might have happened, why do they occur more in men than women, is actually in males, the testicles develop above the kidneys in the fetus. And towards the last trimester of gestation, those testicles actually migrate down from above the kidneys, which are, in the upper back, and they migrate down and they penetrate the abdominal wall and they drop down into the scrotum. We suspect that the area where those testicles penetrate the abdominal wall stays as a relative area of weakness in the abdominal wall. And as males get older and stronger and maybe gain weight or do more physical activity, that relative area of weakness in the abdominal wall can manifest as an orifice that opens up as a hole in the muscle of the abdominal wall, causing hernias more commonly in males than females.
So when should a patient be concerned that they might have a hernia?
So if a patient has any bulging in the groin area that's abnormal, pain out of proportion to normal physical activity, there's a lot of strain that we put in the groin region with doing regular activity. They're responsible for doing any physical activities, the core muscles. And if there's weakness in that core muscle that manifests in a hernia later on with a hole in the core muscle, that can the inside viscera can start penetrating through that hole and causing bulging and pain. So any male who has bulging and pain in the groin area should be examined and see their primary care physician or a surgeon to consideration if there's a hernia there.
And are there consequences, medical consequences of having a hernia?
Yes. So most hernias manifest with pain. But if you wait on a hernia and not get it fixed, that hernia can eventually, the natural history of all hernias, because of their repeated physical activity, will get larger. Not only does the defect get larger, but the herniated stuff into the hernia gets larger, whether it's bowel or whether it's omentum. And later on, if this does not get managed in appropriate timing, it can become an emergency where the bowel gets incarcerated. That means it cannot be reduced back into the abdominal cavity and can start depriving itself of its blood supply. And that becomes a true emergency for a hernia, the presence of a hernia that needs emergent attention and surgery.
And are there risk factors to develop a hernia other than, obviously, as you mentioned, the sex of the patient? Are there other things that can lead to that?
So we see hernias in males, as I mentioned, is the predominant thing. But people who do perform a high level of physical activity, most of my patients, come in and they either their job are very demanding. They lift heavy weights. Patients with chronic obstructive pulmonary disease who cough quite a bit. The coughing and the producing intra-abdominal pressure, high intra-abdominal pressure, can cause a hernia. And of course, obesity. As the patients gain weight, their intra-abdominal pressure can increase and cause those defects to become larger later on in life.
If a patient goes for their routine physical, let's say, and their primary care doctor finds a hernia, should all of those patients come and see you as a surgeon?
So the simple answer is yes. The surgeon should evaluate the hernia, but then the discussion happens with the patient whether the hernia needs to be repaired or not. In general, the general statement we say is not all hernias need to be repaired, but eventually, if they become symptomatic, they need to be repaired. So if the patient is healthy otherwise, they have zero symptoms, this hernia is discovered incidentally, we do something called watchful waiting, where we just don't ignore it, but we keep an eye on it. If it becomes symptomatic, those patients will probably need to go to the operating room and have their hernia fixed. However, if the patient's not a candidate for surgery, either have multiple comorbidities or medical problems, and they don't have symptoms, those patients, we just need to keep an eye on those hernias so they don't become symptomatic and need urgent or emergent intervention. So, not all hernias need to be fixed, but not all hernias need to be watched.
And should a patient be concerned that an incidental hernia turn into a catastrophic problem immediately? Should that be a concern?
No. So in general, there's been multiple studies watching these hernias that are asymptomatic, that become emergent. And, in one of the largest studies, only 4 out of 1,000 patients needed an urgent operation when they're being watchfully observed by their surgeon. So in most patients, those hernias are not going to become catastrophic overnight or a few hours. In my practice, I inform the patient who are competent. If this becomes giving you a hard time, giving you problems, giving you pain, then call us. We always have somebody available and you can be evaluated emergently. And if the hernia becomes very symptomatic with severe pain, nausea, vomiting, and you can't reduce it, then you need to go to emergency room. We're lucky being in the United States that all board certified surgeons are able to repair these hernias with efficacy and with good outcomes.
And if you see a patient with a groin hernia, what sort of options do you give them in terms of what sort of surgery they could have to repair them?
So nowadays, because of the culture of what's going on in the news with mesh, so the first question my patients ask, are you going to use mesh? And mesh is the standard of care in inguinal hernia repair, especially in the United States. I think the mesh is important because it takes the tension off the repair. So you're not really bringing tissue together under a lot of tension. The recurrence rate without mesh can be upwards of 60 to 65%. With the use of mesh, that decreases the recurrence rate to less than 2%. So mesh is important in hernia repair. And then the second question they ask, how are you going to do this operation? Are you going to cut me open or are you going to use the laparoscope? In my practice, the majority of my patients are candidate to have laparoscopic surgery. I advocate for laparoscopic surgery. All the studies show that it has decreased amount of pain in the postoperative recovery time and earlier return to work with using the laparoscope. The earlier studies show that it's better to use the laparoscope as bilateral inguinal hernias or recurrent inguinal hernias. But I think that the best operation that the patient benefit from is the best operation that is tailored to that patient and what the surgeon can offer them best.
Just to back up a little bit, what is mesh exactly? How is it made, and is it really safe?
Yes, so mesh is very safe. It's been around in the United States since the 1950s, introduced from France. And mesh is made out of the two materials that we commonly refer mesh is made out of polyester, which is what most clothes are made out of, or plastic. And it is a mesh. That means it's weaved, or it's the construction of the mesh it looks like a piece of plastic. It's a very thin piece, either polyester or polypropylene. And what it does is allows the body to attack that mesh as a foreign body, builds scar tissue on that mesh. And that scar tissue scars the mesh in place and plugs that hole. The most example I give it to my male patients who have dealt with drywall. It's like having a hole in the drywall and you need to mesh it and put the spackle. I place the mesh and their body makes the scar tissue, which is mostly like the spackle, and plugs that hole and gives them good relief and reduce the recurrence rate of that defect in the abdominal wall.
And just to be clear, if you do a laparoscopic repair, does that always require mesh?
Yes. So it's very difficult to close the hernia primarily with laparoscopic repair without using, nowadays people advocate using the robot. I'm not a user of the robot because it's hard to suture in that small area. But if you try to do primary repair without mesh, as I said, not only the recurrence rate is high, but there's 5 nerves in that area. And if you try to just put sutures of tissue to tissue without using mesh, the chance of you injuring a nerve or entrapping a nerve with these sutures can be high and can cause chronic pain, which is a different problem with these repairs.
And if you do an open or an incision in the groin for repair, how often do you use mesh in those cases still?
So I still use mesh in those cases about 100% of the time. It's very rarely that I would do a repair without mesh. The only time that I recall probably not using mesh if the patient has contamination of the wound, an infection, or the bowel is dead from strangulation. Those are emergent cases where you don't use mesh. But in general, the concept of tension-free repair, that means the mesh takes the tension off the tissue. You don't have to bring the tissue together under a lot of tension, but the tension is on the mesh. The mesh is holding the wound together. Is much better repair and much better outcomes and very less chances of the hernia coming back after this repair.
When would you consider primarily doing an open repair for someone and not, I know you think highly of the laparoscopic repair, but are there some perhaps good patient indications to do an open repair? Absolutely. So if the patient cannot go under general anesthesia, those are patients we can actually do open repair under local anesthesia, where we can actually numb the wound and do an open repair. Unfortunately, with the laparoscope, you do need general anesthesia because most patients cannot tolerate the air that we insufflate in the abdomen to be able to do this hernia laparoscopically. Excuse me, the other things, if the patient's had a previous laparoscopic repair or prostatectomy or had an intervention that made scar tissue in the area of the groin, it's better sometimes to go through the virgin plane that has not been manipulated surgically in the past. And if so they had a laparoscopic repair and they had a recurrence, then we'd go with an open repair. Okay, any prior abdominal or pelvic surgeries make laparoscopy not a good option? It can be. I usually try to get into the preperitoneal space. In doing it laparoscopically, there's a couple ways of doing it. One is called transabdominal, where we actually get into the abdomen and then get into the preperitoneal space. Think of the abdominal wall as multiple layers to get into the layers of the abdominal wall after we insert into the abdomen. In patients who've had previous abdominal surgeries or multiple surgery, this might be difficult and you have to go through a lot of adhesions and it's not worth the technical difficulty that may injure the patient. And in that case, you do it open. But in my practice, I enter into the preperitoneal space without entering into the abdomen. That's most of my hernia surgery. So if the patient had the previous abdominal
surgery, I can usually get into the preperitoneal space without entering into the abdomen. The contraindications were patients we don't want to do that on, patients who had radiation to their pelvis, or as I mentioned, who had a prostatectomy and their preperitoneal space has been violated, and that space will get scarred down, and it's very hard to reestablish that space to do a safe operation.
So there are a lot of people on anticoagulants, antiplatelet drugs, things like that. Is that safe to do one way or the other, or are they equivalent if people are on those medications?
So it's a relative contraindication, anticoagulation, because you're making the area of dissection is larger than what we do in an open case. So again, in surgery in general, the nice thing about surgery is you tailor the operation to the patient. Not every operation is the same. Not every patient is the same. So if a patient is, say, on Plavix for AFib and their cardiologist say it's safe to stop the Plavix or the anticoagulant for a longer period of time, those patients are still candidate for laparoscopic surgery. You can stop it before the surgery and keep holding it for a few days after the surgery, and doing it laparoscopically with a large area dissection is okay. But let's say the patient is on anticoagulation that cannot be stopped, or it can be stopped only for the surgery, and it's dangerous to stop it for a long period of time. Those patients, probably it's better to do it open so you don't have a larger area dissection and less chance of bleeding from a larger area that can predispose the patient to postoperative bleeding and hematomas if they need to go back on the anticoagulation right away.
And relative laparoscopic to open, how about long-term outcomes? Are there major differences between the two operations, do you think?
Most of the studies were actually in the early 2000s when laparoscopy was new. I think nowadays the laparoscopic is a little more superior because we tend to be able to cover a larger area of the groin to reinforce it with mesh than open. But in general, the older studies show that after 6 months, they're equivalent in terms of their outcome, in terms of the patient's return back to work. There is a little higher incidence of chronic pain with the open repair. As I mentioned, there are 5 nerves in the area of the groin, and these are sensitive nerves. The chance of injuring those nerves or entrapping those nerves is much less with laparoscopy. It's not obsolete that you don't injure it, but it's less with laparoscopy. So the incidence of chronic pain has been a little higher with the open repair than the laparoscopic repair. But again, the difference is very small. It's 3 to 6%. It's still small, 6% with the open and 3% laparoscopic. It's small in general, but it's still a considerable difference when you think about it's about 100% difference when you're talking between laparoscopic to open.
And should men be concerned about infertility after a hernia repair?
Not. It's very rare. There's been some studies coming out of Sweden where it says actually reduced sperm count after laparoscopic repair because you're operating in the area where the vas deferens is, which is the vessel or that takes the sperm from the testicles to the urethra. But those studies did not manifest with decreased fertility. So even though there was lesser sperm count, there was no chance of infertility. So most surgeons who are able to do this open or laparoscopic, we try to preserve the cord vessels, including the vas deferens and the vessels that feed the testicles. So the chance of infertility is small, but it's never zero.
In an adult who has a one-sided hernia, is there advantage to do laparoscopy and fix the other side prophylactically?
Good question. So I used to do that in the beginning. I used to look at the other side because the advantage of going laparoscopically is that you can look and see both sides at the same time and fix them. And then as I developed my practice, patients will come back and say, well, you fixed my left side, which was hurting, but my right side wasn't hurting. And now I feel a little bit uncomfortable sensation of the mesh, even though I had no symptoms. So in general, in my practice, if the patient is not symptomatic and the hernia is not large on the other side, I usually do not address it and fix it until they become symptomatic. But if the patient wishes for their hernias to be fixed at the same time, then yes, we do that. But like the common saying, if it ain't broke, don't fix it. That's the principle I guide by. And I usually, when I do the TEP repair, which is the preperitoneal repair, I do not look at the other side if the patient has 0 symptoms.
Well, that sounds like good advice that we'll end on today. So thank you, Dr. Alaedeen, and thanks everyone for tuning into MD Insights today.